Malnutrition and tuberculosis are both problems of underdeveloped regions of the world. Most of these two problems tend to interact with each other. Tuberculosis mortality rate in different economics group in a community tend to vary inversely with their economic levels. Similarly, nutritional status is significantly lower in patients with active tuberculosis compared with healthy controls. Malnutrition can lead to secondary immunodeficiency that increase the host's susceptibility to infection. In patients with tuberculosis, it leads to reduction in appetite, nutrient malabsorption, micronutrient malabsorption, and altered metabolism, leading to wasting. The protein energy malnutrition and micronutrients deficiencies increase the risk of tuberculosis. It has been found that malnutrition tuberculosis patients have delayed recovery and higher mortality rate than well-nutritioned patients. Nutritional status of patients improves during tuberculosis. High prevalence of human immunodeficiency infection in the underdeveloped countries further aggravates the problem of malnutrition and tuberculosis. Effect of malnutrition on childhood tuberculosis and tuberculin skin test are other important considerations. Nutritional supplementation may represent a novel approach for faster recovery in tuberculosis patients. In addition, raising nutritional status of population may prove to be an effective measure to control tuberculosis in underdeveloped areas of world. Effects of malnutrition and tuberculosis. Epidemiological studies. The host protective immune mechanism of infection with Mycobacterium tuberculosis depends critically on the interaction and cooperation between monocyte macrophages and lymphocytes and their cytokines. Substantial experimental evidence suggests that malnutrition can lead to secondary immunodeficiency that increases the host's susceptibility to infection. Increased risk of tuberculosis can result from alteration in the individual protective function of or the interaction between lymphocytes and macrophages because of nutritional insult. Protein malnutrition has been identified as an important risk factor for the predisposition to intracellular infection leading to death. Cytokines play a central role in mediating antimicrobial interleukin second is required to initiate and amplify immune responses. First, dietary deficiency causes thymic atrophy and impairs the generation and maturation of lymphocytes in animal models of tuberculosis, resulting in reduced number of immunocompetent cells in lymphoid compartments, including the blood. Second, deficiency of protein and their nutrients impair cells function. Effects of tuberculosis in nutritional status. Tuberculosis patients have been found to have lower serum albumin concentration than control. Tuberculosis is probably associated with more severe malnutrition than other chronic illnesses. In an Indian study, the nutritional status of patients with tuberculosis was worse than that of those with leprosy. Failure to channel food protein into endogenous protein synthesis has been termed anabolic block. This anabolic block represents one of the mechanisms for wasting in tuberculosis and other inflammatory status. Anorexia is also a contributing factor for wasting in tuberculosis. Increased production of cytokines with lipolytic and proteolytic activity cause increased Energy expenditure in tuberculosis. Leptin may also play an important role in wasting. Role of micronutrients. Because of diverse metabolic characteristics and functions, micronutrients have presently been accepted as essential for optimum human health. Micronutrients deficiency is considered to be the most frequent cause of secondary immunodeficiency and infection-related morbidity, including tuberculosis. Zinc deficiency affects the host defenses in a variety of ways. It results in decreased phagocytosis and leads to a reduced number of circulating tuberculous cells and reduced tuberculin reactivity, at least in animals. Zinc has essential role in vitamin A metabolism. Studies in humans and animals have shown that zinc deficiency impairs the synthesis of retinal binding proteins and reduces plasma retinal concentration. Therefore, it appears that zinc supplementation has a beneficial effect on vitamin A metabolism, which has important role in tuberculosis. Vitamin A. It has been shown that vitamin A has immunocompetent role in human tuberculosis. Vitamin A was reported to inhibit multiplication of virulent bacilli in cultured human macrophages. In addition, vitamin A has a vital role in lymphocyte proliferation and maintaining the function of epithelial tissues. Vitamin A is essential for normal functioning of T and B lymphocytes, macrophages activity, and generation of antibody response. Vitamin D. Vitamin D plays a role in the function of macrophages, key factor in host resistance in tuberculosis. Abnormalities in vitamin D status have been reported in tuberculosis. Vitamin E. In many studies, concentration of vitamin E was found to be significantly lower in tuberculosis patients. These have linked the vitamin C deficiency with the tuberculosis. Selenium, the essential trace element. Selenium has an important function in maintaining the immune process and thus may have a critical role in clearance of microbacteria. Selenium have been found a significant factor in the relative risk for developing microbacterial disease in HIV positive patients. And anemia is highly prevalent among adults with pulmonary tuberculosis. Cholesterol. Hypercholesterolemia is common among tuberculosis patients and is associated with mortality in military tuberculosis cases. Nutritional assessment will include the following: clinical assessment that includes a nutritional oriented history and a nutritional oriented examination, anthropometric assessment, dietary assessment, and laboratory assessment wherever feasible and appropriate. Anthropometric assessment. Body mass index. This is a measure of weight adjusted for height which is calculated by dividing the weight in kg by square of height in meters. BMI is useful as a measure of the fat and muscle mass of the body. It is also useful as an indicator of risk of morbidity and mortality. The increase linearly in subjects with both BMI higher and lower than normal. At higher BMI, the risk of CVD deaths increases, while at lower BMI subjects, are at a greater risk of dying due to respiratory causes, including TB. Mild upper circumferences (MUAC) is the circumference of the left upper arm measured midway between the tip of the shoulder and elbow. It is an indicator of nutritional status, fat and protein stores, and lacks the BMI is also independent of height. It can be measured in pregnant women and those who are unable to stand. MUSC less than 22 centimeter in women correlates with a BMI of less than 18.5 kg per meter square, and it is suggestive of undernutrition. What should be avoided? Alcohol in any form of dangerous for the patient as it increases the risk of drugs toxicity, and the patient should be supported in his attempt to quit alcohol. Carbonated drinks, excess of tea and coffee, or their intake with food, tobacco and tobacco products, excess of spices and salt. Patients with TB have a poor appetite initially and should be encouraged to have more frequent food, 3 meals and 3 snacks.